The next speaker is Dr. Nisreen Al-Musaileem. Dr. Nisreen is a highly skilled otolaryngologist with extensive clinical experience and advanced fellowship training. She completed facial and plastic reconstructive surgery fellowship at the University of Toronto in 2023 till 2024. Rhinology and sleep surgery fellowship at Tufts University 2022 and 2023. And advanced endoscopic sinus surgery fellowship at Augusta University 2022-2023. Very active Dr. Nisreen since 2015. Dr. Musaileem has served as a senior specialist at Farwaniya Hospital in Kuwait, where she managed a high volume of ENT practice, performing over 1,400 surgical cases annually, including major procedures like FIS, rhinoplasty, thyroidectomy, and neck mass surgeries, alongside handling emergency on-call cases. The lecture is Sino-nasal disease, what the clinician needs from the radiologist. So, Dr. Nisreen, you can start.
Good morning, and thank you all. Thank you for the invitation, and thank you for the introduction. I'm presenting what the rhinologists need to know from radiologists before FES. Because of the excellent bone details provided by the CT, CT scans represent the gold standard in planning of functional endoscopic sinus surgery. And however, the perspective to CT is different in radiologists and otolaryngologists. Usually, radiologists focus on the extent and effect of the disease. However, also the rhinologists always focus on the anatomical variances on CT scan. Why is that? Because it's relatively like all nasal cavity are different, or all nasal cavities are different from each other. Like there are a lot of variabilities, and it's relatively common to have anatomical variations. And it affects the surgical planning, and it's responsible for, and usually, like for example, if we have a conchoblusa, it doesn't cause rhinosinusitis, but it's responsible of lack of response to treatment, and it's also responsible for recurrence. And it usually causes a high risk during FES. For example, in this CT, you can see a lot of anatomical variations. Of course, you can see the striking conchoblusa and deviated nasal septum and hypoplastic maxillary sinuses. But also, we always miss something, which is the pneumatized crista galli. For example, if we have a case of chronic rhinosinusitis and we have pneumatized crista galli, we usually missed it as an ethmoid. And during FES, especially in the era of instrumentation, the debrider and shaver that we're using during FES, we can easily go into the cranial vault, and we can easily missed it, for example, like we usually missed it and won't open it, and it will cause recurrence in the future of the chronic rhinosinusitis. So rhinology centers start to develop structured reporting for radiologists and structured operation planning as template or checklists, and they found that the structured reporting and structured operative planning usually significantly increased completeness of radiological reports and operation planning and surgical management of paranasal sinuses and diseases. And it's always enhanced the learning curve, both in radiology residents and otolaryngology residents. So it decreased potential risk during endoscopic sinus surgery in radiology centers. So in University of Columbia in New York, they published a systemic review of the literature, and they collected all published checklists or templates that used by rhinologists to review the CT scans, and they presented in the annual American Academy on 2022. And it contains like a structured and detailed review. So if the younger otolaryngologist or younger rhinologist went through these checklists, they usually won't miss anything during the review and operative planning of the CT sinus. So now I'm going to talk in details what the rhinologists need from the CT sinus scan. So first of all, we need to know the disease, of course, the disease location and type overall of the lesion. So first we need to know, is it right or left or bilateral, and what's the location, if it's maxillary, anterior ethmoid or posterior ethmoid, and what type of opacification we have, like is it heterogeneous or homogeneous or fungal, and if there's a mass, is it pedicled or not, and if there is any vascular thrombosis, like in a non-contrast study, so it's usually like in a contrasted study, and is there a polyp or polypoidal disease, and do we have a central compartment and a topic patient? Is there any bony erosions, bony remodeling, and is there any intracranial or interorbital extension? So this is what we get, first of all, from disease location and overall type. And later, which is more important in operative planning, we need to know the anatomical variations. So we structurally go into, we divided it to six parts. First of all, when we review the nasal cavity, we want to see if there is any anatomical variation, such as septal deviation, concaballusa, or prior turbinate resection by prior surgeries, or olfactory cleft changes. For example, we have this concaballusa deviated septum here and resected turbinate, middle turbinate here, and we have also olfactory cleft changes, and this is an encephalocele case. And it was caused by septoplasty years ago. So also, then next we go to maxillary sinus, and we want to check if there is an Haller cell. The importance of Haller cell, if we don't, for example, address it on FES, usually a patient will have recurrence because of the obstruction, and not because it's a causative factor, but because the treatment won't reach the maxillary sinus because of the Haller cell obstruction. So we usually address it on operative planning and address it on FES. And if there is osteomalatal complex obstruction or odontogenic otology in the maxillary sinus, like here in this CT scan, we can see in this one we see oroantral fistula, and we have to study the uncinate process and its attachment. For example, we have a telectatic uncinate process in the CT scan, and we have hypoplastic maxillary sinus on this scan. Okay, and this is an example of obstructed closed osteomalatal complex and open one. And we have three attachment of the uncinate process, of the superior attachment of the uncinate process, and it's really important in operative planning because it shows us where is the access to the frontal recess when we are doing frontal surgery, frontal sinus surgery. So we have the uncinate process attached to the lamina papricia, or to the skull base, or to the middle turbinate in type 3. Then we want to study the ethmoids, and most importantly, when studying the ethmoid. So when we study ethmoid sinuses, the most important thing is to check the Kurz classification, to know how deep is the olfactory recess. And then the next important thing is the anterior and posterior ethmoid artery are in the skull base or below the skull base. So I feel really bad when I have a patient with with below skull base ethmoidal arteries, especially if an extensive disease with chronic rhinosinusitis. So planning is really important in this stage. And also when we study sphenoid sinus, we have to make sure that there is no anode cells, which is the posterior extension of the ethmoid sinus to the sphenoid. And then we need to check if there is like pneumatization of the anterior clinoid or the pterygoid process. So if we have more pneumatization of the sphenoids, then we will have some sort of dehiscence in the optic nerves and also in the internal carotid artery here. So it's really dangerous if we have it. And also the third thing, we need to check where is the insertion of the intersinus septum in this sphenoid sinus. So usually the intersinus septum is anchored on a dehiscence part of the internal carotid artery or the optic nerve or so ever. Then, when we study the frontal sinus, we need to determine the diameter of the beak. For example, if I have this wide beak, like in this example, I usually open the drill forehand because I need to drill this large beak. The treatment after FES will not reach the frontal sinus. I will have recurrence if I have this large thick beak at this one. The other thing, I need to check the frontal outflow tract. Is it patent opacified? Is it medial or lateral? Is it is the anterior table dehiscence or the posterior table dehiscence? So because with instrumentation, I can't go all the way through, and usually in some sort of blind instrumentation when I go into the frontal sinus. So it's all important for operative planning and looking at it and studying it forehand is really important. Also, I need to know what type of frontal sinus I'm encountering. For example, we have the International Frontal Sinus Anatomy classification that I go with all the time. For example, if we have supra-agar cell or supra-agar frontal cell, that will include the access to the frontal sinus more. And if I have suprabular cell or suprafrontal bular cell, also it will include the outflow anteriorly from the anterior table. When I have supraorbital ethmoid cell, I would worry more, and I would do a wide frontal sinusotomy and use my 70-degree scopes and try my best to address the supraorbital ethmoid cell. And lastly, the skull base and orbit, we need to check if we have skull base defect or orbital thinning or dehiscence. And one of the ways that I usually prevent any trauma to the skull base when I'm doing an ethmoid or a sphenoid sinus FES, I usually do the measurement of maxillary to ethmoid height ratio. So how can I do? I usually do it. I go to the highest cut of the maxillary sinus, and then I measure it from the floor, and then I go to the cut of the anterior ethmoid artery, and I do mid-orbital vertical line, and in that line I measure the ethmoid height to the skull base. And if it's 1-to-1, I feel okay, and usually I don't go above the roof of the maxillary sinus. About I'll be always in the inferior 1/3 of the ethmoid sinus, And the worst scenario, if I have more than the ratio, if the ratio is more than 2 to 1 of the maxillary to ethmoid height. Lastly, in the skull base, also we have Gera classification, which is the angle between the lateral lamella and the cribriform plate, like in the example here. And the best angle if it's more than 80 degrees, and when it gets lower, the risk of skull base and CSF leak is higher, and I have to be cautious. And that's the references. And thank you so much.
Thank you, Dr. Nisreen.